So I have a couple of learning objectives for you. The first is to define the role of whole body MRI in surveillance, as we've heard already. So this will be hopefully giving it from the imaging perspective, and as the caveat that I'm a paediatric radiologist, so more paediatrics than adults, but the radiology perspective, and from that perspective, a little bit more information about the technique itself. First up, the surveillance imaging and CPS, or cancer predisposition syndromes, which is really front and centre at this meeting, and I think particularly drawing attention to the LFSA scientific and medical advisors' welcome note in the newsletter for this meeting, and really highlighting how important this morning's session is in the role of whole body MRI screening in the surveillance of Li-Fraumeni syndrome. I think it's really, we've already heard this morning some of these elements of it, and I can't emphasise enough as a radiologist why it matters for us to be aware of how surveillance fits into the overall patient pathway and experience. We have some patients who are asymptomatic for whom surveillance is the initial entry into radiology, as well as other arms of surveillance. And we have other patients who present symptomatically, and as we've seen with some of the presentations with the case from Anita's patient, that having that parallel imaging pathway with surveillance and the other aspects of surveillance is really important to interleave with the diagnosis and staging of new tumours and assessing treatment response and follow-up. We've looked at our patient population with DICER1 syndrome to try and extrapolate which of those studies have been primarily performed because of surveillance versus diagnosis, treatment and follow-up and unrelated imaging. Children can still fall over and get a fractured forearm, for example. And out of the over 600 study request forms that we looked at, we felt that it was the items in blue here that you can see that were done primarily for surveillance. And very important to us is trying to minimise risk as part of surveillance, particularly when a patient is asymptomatic. And we were very pleased in these patients to find that the ultrasound and MR examinations, which are without ionising radiation, were the ones that were done most commonly. So I think it's really critical, as we talk about surveillance imaging in particular, that we think about it in terms of harmonising it with those other streams of imaging that we are also going to be doing simultaneously or in the future. If we can answer the question with one imaging test instead of many, we certainly want to. And if we are doing several tests, really being mindful of trying to coordinate those tests so that people are coming in once rather than 3 times and not doing one test today and another in 2 weeks. If we can possibly be aware of that and coordinate that, I think that's really critical. When we talk about surveillance imaging overall, we have to balance the risk and the benefit. Again, we have patients who are coming to us who are asymptomatic, so we don't want to add to your disease burden. And so the things that we think about are the radiation risk, contrast, whether it's iodine in CTs or gadolinium in MRI, the risk for sedation in our children. There are costs, not only dollar, but in terms of time and the psychological impact, which we've seen in the French study looking at that, and I was very relieved to know that that was not a major concern. And certainly false positives have been a very predominant theme this morning, and I'm going to share a little bit more from the radiology side with you. So when we look at whole body MRI surveillance in particular and think about those risks of radiation and cost and sedation and contrast and sedation, how does that impact? Are they never, always, rarely, or it depends? So how does that play out? So from the radiation perspective, I'm pleased to say that there is no ionising radiation. And so that's a huge thing. We're not adding that additional risk of potential malignancy over the lifetime to the patients, particularly our young patients. And in Li-Fraumeni, we are aware that there is an increased sensitivity to radiation. So that's a really critical arm of the MRI pathway. Contrast, fortunately, is rarely part of our protocols for whole body MRI. We tend to use it if we're doing targeted imaging for problem solving or comprehensive imaging of the brain. We won't give it if there's a severe renal impairment. And there is a new question coming on the scene of deposition, beyond the scope and detail for today, but I'm certainly happy to talk to people later if they would like to know more. And we're certainly looking at ways to try and avoid contrast if we can, and we're looking at that in our osteosarcoma investigations, poster 1, if you want to have a look and chat with me there. And sedation and the need for it really depends upon the patient's age and the development. But we always need to be aware of the overall rules of MR safety and avoiding patients with metallic foreign bodies and certain implants. You're a very educated group when it comes to the potential benefits, and we've heard a lot of that this morning about the aim of early detection and with the awareness of increased germline mutations in paediatric cancers, and the improved outcomes have been discussed. And we know we're in certain other groups like Beckwith-Wiedemann and hereditary retinoblastoma that there have been some studies demonstrating that as well. 2011 was really a standout year from the point of view of surveillance imaging for Li-Fraumeni. That was the first of Anita's first author papers in Lancet Oncology. It was also the year that David Malkin joined with my colleagues in radiology here at Sick Kids and bringing together a list of recommendations for the common cancer predisposition syndromes, of which Li-Fraumeni syndrome was one. And this is certainly a game changer in that this was the taking whole body imaging from research to clinical, and a real tipping point in terms of how we go about screening. There's been a lot of work since then, and you've seen some other examples already. And I think David Malkin and Garrett Brodeau brought a group of us together to look at the different surveillance protocols and recommendations for a range of different syndromes. And from that, we were able to extrapolate 8 that we felt that whole body MRI may have a role, some with more strong evidence than others, and Li-Fraumeni syndrome is front and centre of that. How that comes into practice for me on a daily basis as a clinical radiologist is the number of scans that I'm looking at each year. In the last 12 months, I've looked at, not personally, my group and I have looked at over 350 whole body MRIs. About a third of those are done for oncologic indications, and within that group, just less than 20% are our patients with Li-Fraumeni syndrome. So 18 studies in all over the last 12 months, and we're one of the centres that do a lot of them. So these are not commonly performed studies, even though on the spectrum there are a lot of studies done. So what is whole body MRI? I think the key thing here is really that it is a multi-region contiguous scan from the head to toes or vertex to heels. One of the things that over and above having the large field of view, it gives us the opportunity to also do targeted imaging, and that can be the brain scans, as we've seen, and also breast MRI in the older patients, but also the opportunity to problem solve if we see an area that concerns us at the time of the whole body MRI. And from the protocol from the ACR guidelines, we've recommending 12-monthly and whole body MRI with dedicated brain imaging, and in those patients that don't need a GA, interleaving that with whole body MRI alone, together with the abdominopelvic ultrasound, and this just being the imaging arm. This is what it looks like. You've seen some examples already this morning. The patient is supine on the table, arms by the side, and there are a number of you who could give this part of it better than me, I'm sure. But we do several stations, and the number of these stations which are required consecutively depend upon the height of the patient, and then they merge together to create this whole body image. And we'll have a series of those from front to back. These are the most recent published protocols, and this from our paper in 2016. In that point, we were only doing STIR. We've since added diffusion-weighted imaging, and so our imaging time is now closer to the 35 to 40 minutes. We do a number of different imaging planes, but primarily coronal. And this is an example of how this looks. This is not a Li-Fraumeni patient that had a prior brain tumour, but this is an example of how STIR looks. Very large field of view, beautiful anatomy. We can see things like the liver and the spleen and the kidneys here, evidence of previous brain tumour. I'm not sure if the eagle-eyed members of the audience will note, but down here on the left calf we have a little bright spot, and on this diffusion-weighted imaging, which is inverted to look like a PET scan, we can see that it's a dark spot, perhaps a little bit easier to see. We see things like the brain and the kidneys and the spleen as normally dark, but this is not something that we expect to see in this location. So adding this extra sequence in allows us to improve lesion detection. So we'd probably have seen it on that sequence, but we're not going to miss it, we hope, on that. How we analyse this as a radiologist, we actually look at each individual station and the smaller field of views in addition to the larger field of views. So we would probably see this on this image here, but certainly this makes it much easier. But the added advantage of diffusion-weighted imaging is it allows us to characterise that. So you heard from Sharon's talk that there are some technologies that will hopefully improve our sensitivities and improve our true positive rate, reduce our false negative rate. And in this case, by looking at the different signal characteristics, it allows me to know with more confidence that this is a lesion that I can be comfortable to just watch and not intervene, and is in keeping with a cyst rather than a more concerning solid lesion. There are some pitfalls to whole body MRI, and this is where some of the issues with regards to false negatives and false positives comes into play. When we merge those different stations, we sometimes get an artefact called a stitch artefact, where we can have a little bit of loss of signal in that location. Our patient size does make a difference. So on the left here we have an 11-year-old boy. You can see, depending on the scanner, that might be 60 or 70 centimetres wide, and he fits in very neatly. Our 17-year-old girl over here is a little larger, and we don't get such good visualisation. And there was a nice discussion of a forearm lesion. And one way that to problem solve with that is at the end of the study, if we feel we haven't got adequate information here, we can do an additional sequence with the patient's arms above their head. A little uncomfortable to lie like that for 45 minutes, but certainly easy to do at the end of the exam to improve conspicuity of any lesions there. And motion artefact is a constant concern for us in MRI. But there are lots of advantages: no ionising radiation, superior soft tissue contrast, large field of view, and the chance to do regional imaging. That comes at a price, though, and we've already heard discussion of the difficulties with screening and balancing sensitivities and specificities. We're certainly finding that we are seeing more bony infiltrates, which can be difficult with regards to low specificity. We're seeing them better than we're seeing with PET. When it comes to sensitivity, there is a size threshold. We're not completely certain of what that size threshold is, but certainly we know that for some lung lesions at the moment, the reported literature suggests that we're not very good at picking those at less than 6 millimetres, and similarly for lymph nodes. While we have great opportunities with regards to doing regional imaging, it does add time, and time adds motion, and that means that we're going to be less successful in picking up lesions. One way to deal with motion is anaesthesia, and certainly for our younger patients we certainly employ that in order to do these scans. There are other alternatives, however, to try and minimise the risk of anaesthesia. In our very young patients under 6 months, we can use a feed and sleep technique where we have them fasting until just before the scan, they have a feed and then they get swaddled. We have the benefit of having a lovely Lucy, the Labrador here, and her off-sighted Joe Summers, and we have been using that the service of animal-assisted therapy for the last 2 years very successfully. And our youngest patient to date is a patient undergoing bowel imaging at 3 years, 4 months without anaesthesia. So we have opportunities to use different and novel techniques to really help us minimise the risk of surveillance. We want to optimise the good bits and we want to minimise the bad bits. And mock MRI is another opportunity to do that we're in the process of implementing at Sick Kids, but we have in other centres such as my hometown in Brisbane, Australia. So what do we see? We've already seen some examples on, and I'll share some more with you now. When we looked at our patients here who underwent surveillance imaging for a range of different cancer predisposition syndromes, of whom 23 patients had Li-Fraumeni syndrome, we did 130 MRIs and 115 of them had abnormalities. And we tried to extrapolate, much as we've seen with other cases this morning, what related to the cancer predisposition syndrome, what did not. And our numbers are absolutely the same as what have been reported just before. We've got 6% of abnormalities that were malignancies related to CPS. So I think we're all around about the same level, which is kind of reassuring in terms of what we're hoping to obtain and really optimise our tests. My colleagues from Children's Hospital of Philadelphia did a similar study in 2015, and they looked at 24 patients who underwent 50 MRIs, 10 patients with Li-Fraumeni syndrome. A third of these patients were referred because of prior malignancy, and 2/3 because there was a positive family history. 9 abnormalities were identified, and here's the concern. There were 3 of the 9 abnormalities were false positives. So the key thing for us as radiologists is we want to try and minimise both false negatives and false positives. And with regards to false positives, the issues there relate to trying to avoid doing radiation tests and further investigations as well as invasive tests. One way that we've tried to deal with this is developing an anatomic checklist. This is from the ASA papers, and I worked with Stefan Voss from Boston and Lisa States from CHOP to develop this. And essentially, looking at those syndromes which have, for which whole body MRI is most commonly employed, we've looked at those lesions, the sites of those lesions, to really hone in our attention to those areas that are most likely to have lesions relating to the syndrome. In bold, for example, in Li-Fraumeni syndrome, brain, breast, bone and muscle are coming up as our areas that we want to pay particular attention to minimise our false negatives, those which have got moderate associations and not bolded, and in a subgroup such as the Brazilian founder mutation, we've annotated those with a superscript of B. So these drew our attention to those areas to improve our detection rate, we hope, and those areas that are don't have an X next to them are less likely to be positive. We don't ignore them, but we can be more conservative in our approach. And you've seen the impact of whole body MRI on that and the range of tumours that have been detected in the study through the prospective study with Anita and Mandy Ballinger's meta-analysis. We've already seen this patient a little bit earlier with a large right suprarenal mass, an adrenocortical carcinoma picked up on a whole body MRI in a toddler. The patient with the chest wall mass is almost like a cauliflower, the osteosarcoma or chondrosarcoma arising from the rib. This patient had had previous MRIs, so I went back to look to see what I could learn to improve my detection rate. And I'm involved with educating a lot of trainees and other centres, and so it's really important for me to minimise false negatives. So I've already talked to you about a couple of the issues. One in this particular case, when we went back to the very earliest scan, this is close to the lymph nodes and very much similar in appearance to that. So we know that when we look at the axilla and we see lymph nodes, we have to pay special attention to the bones in that region. And the scan that came after that, well, you already know, stitch artefact. This was right at the level of the stitch artefact. So those become review areas that we need to pay special attention to improve our detection rate. High-risk lesions, such as in the bones, osteosarcoma being the key thing, well, we want to pay more attention and make sure that we're not missing something if we can avoid it, but also not overcall. So if we see something like this bright area in the tibia, we can then do some targeted imaging at the time and go, yep, there is something there. This one I'm worried about because this patient's at risk of osteosarcoma. So we did go on and do a plain film, which was reassuring, but in addition, we went on a month later to do a dedicated MRI of that knee, and that had resolved, so we could be more comfortable. But we stepped in early to evaluate that. So a false positive, yes, but something that we felt that we needed to evaluate because of the high risk. In comparison, one of the earliest diffusion images showed us some area of abnormality in the abdomen here. It wasn't seen on the standard SIR, which had been our usual before that, but we knew the patient was coming for ultrasound imaging as part of their standard surveillance protocol within a matter of a few weeks, and we just made sure we paid special attention to that area, and we were very confident that that was just a normal regional lymph node, and this is part of our learning curve. So in this one, it was an area that was not so concerning. We could afford to be a little bit more gentle in our approach to stepping in. So this is the future direction that I see for whole body imaging in surveillance of cancer predisposition syndromes. I think we have techniques that are going to come on the horizon soon that will improve our detection of lung nodules. You can see this in the MRI and confirmed on the CT. As PET doses go down, perhaps that gives us another avenue to better characterise lesions. 3D volumetric techniques and other fast sequences will help. And I think we'll be able to add in quantitative and other contrast agents also to allow us to better detect and reduce the false negatives and improve on our characterisation of lesions with fewer false positives. So I hope that I've been able to share with you that there is a role for whole body MRI and Li-Fraumeni syndrome surveillance, but we do need to be aware of harmonising it with other imaging. It's relatively fast and sensitive with few risks, but we do have to try and look at specificity and dealing with false positives. And I think there are avenues to do this, and Sharon and I did not collude beforehand, but we really have systems that we can put in place to try and help with our detection rate, Anatomic Checklist being one and very systematic review being the other. And so I think that there are opportunities to improve on it and learn. So thank you very much to my colleagues from literally around the world who have supported and educated me, and particularly our patients who have done so. I'm very happy to be contacted with any questions, and anyone who's interested in looking at alternatives to contrast for our osteosarcoma, we can look at poster one together. Thank you.
Maybe time for one question now. If there's any radiology aficionados here. Sorry.
I'm definitely not a radiology aficionado, so thank you so much for that information. I think it's incredibly important. One question I had, I think may pertain a little bit more toward the adult patients, is with the increased detection of these lung nodules and some of them turning out to be lung cancer. Obviously, in adults, follow-up of these lung nodules that we find very commonly is challenging, even though they don't have the risk factors. And one thing that we've been exploring with our screening population at the NIH is the ultra-low-dose chest CT, which is basically the equivalent of getting 2 chest X-rays.
Absolutely.
With great resolution of images, and comparing it to the kind of standard dose CTs, they seem very comparable as far as detection. What are your thoughts on technologies like that, where it does give a little bit of radiation, but maybe a lot more information for specific lesions?
Absolutely. I think those things have great appeal, and tomosynthesis is another one, which is basically borrowing on old technology. And I think those things for sure have great opportunity to help. I think as a in our paediatric patients, we kind of prefer no dose to low dose. So I don't think it should be dismissed, but I think that's one of the things that's my bias. But I think in the adult population, for sure, the risk of in the general community is less, and I think that's a good opportunity. I am mindful in our Li-Fraumeni patients that any radiation is something we want to try and minimise. I think that the other thing, and the appeal about trying to optimise lung MR, is that if we can do it as one test, that would be great. And there certainly are some work underway and working with one of our research scientists here at Sick Kids to be trying to develop some of those aspects of it. So I think looking at all of them together is the answer. Thank you.
Great. Thank you very much, Mary-Louise.